Thanks so much for be with us today in this session. This is a session for the teens and adults with patients with DND. We have our facilitator, which is Eloi Breton-Paré. I'm pronouncing that right? Sorry if I butcher. And then as speakers, we have Dr. Lucy Roche from cardiology. Lucy Roche is attending from the Medical School of the Leader University. She spent 1 year extracorporeal lab support fellow at the Freeman Hospital, Newcastle, before completing pediatric cardiology training. Also at the Freeman Hospital, and between 2007 and 2009, she was a Philip Whittle Heart Failure Fellow at the Hospital for Sick Children, and she completed fellowship training in adult congenital heart disease in Toronto General Hospital, which she's actually working there. Is that right? That's the one I got. I'm sorry. Okay. And basically, she's seeing all our patients with Duchenne on the heart perspective at Toronto General. Now, on the other side, we have Dr. Adam Rapoport here, that it's a colleague. I work with him closely. He's from the PACS team, which is palliative care or pediatric advanced care team, actually from SickKids. He's a giant, nice person. So that's what I can tell you. Like, he's just super compassionate. I mean, I can go through the bio and all the academic. He's an expert on what he does, but he's a super nice and expert on and compassionate person. And so it's someone you want to talk. That's the person you need to. And then lastly is Dr. Charles Kassardjian that actually met a few years ago. He's my colleague on the adult side, doing neuromuscular in the hospital for in St. Mike's Hospital. And I found in Charles a person that actually could send all the muscular patients from the myopathy perspective, and he has actually tried, and he will actually tell you all the gaps and difficulties on the transition that you probably experience as a parent. He will tell you what are the gaps on the adult side from the, I guess, the health perspective component. So with that, I'm going to let you actually give some questions, but if you have questions as well, please raise your hand and I'll just pass over the microphone. Okay. Yes.
So, as young people with DMD get older, what are the most important things they and their families can do to stay as independent and active as possible?
Thank you. So thanks for inviting me. I really, really appreciate it. As Hernan was saying, so I work at St. Mike's, and over the years, I do neuromuscular kind of in general, but over the years, my practice has kind of shifted a little bit to be more muscle diseases, both inflammatory, acquired muscle diseases, but also muscular dystrophies and other genetic muscle diseases. So we've kind of built that up a little bit, but as I will tell you guys, and sorry, I have some notes because these questions were tough questions actually, and so I just wanted to make sure that I got everything across properly. So if I'm looking at my phone, that's why. But to answer the question first, the most important things, I think it's what I often try to tell families when I first meet them is the importance of early communication. So not to hide things from their physicians, because if they don't feel comfortable bringing something up right away and then it becomes a bigger problem later, it becomes much, much harder to manage it and to treat it. And you guys, I can go on for hours just about the gaps in the adult system that you might not experience as much at a wonderful, institution that's a little bit more comprehensive, like SickKids, where everything is sort of in one bubble. It's not quite like that in the adult world. And so just because of the long duration sometimes to get care, that leads to more delays. So if you don't bring something up early and then you delay it, there's going to be more delays when we're trying to find a solution for it, because every referral, every test we do takes X amount of time to get done, which is quite long, unfortunately. So that's one thing. I also always try to be proactive with the cardiac and respiratory care, and we can hear a little bit about that here, but we talk about that stuff right from the beginning, even if it's not a primary issue that comes up. And then the other things I talk about with patients very, very, and their families very, very early on are exercise and diet. So what I've been doing lately is actually giving out an exercise prescription. So instead of prescription for medication, it's actually an exercise prescription with sort of some guidelines on how much exercise to do, what kinds of exercise to do. The problem is this is not truthfully particularly evidence-based. There's not a lot of strong evidence for it. But my rationale is always doing some exercise is better than not exercising for fear of doing some sort of harm. I think you're more likely to harm yourself by not doing something than by doing something intelligently and carefully. And then we talk a lot about diet, maintaining healthy weight. Vitamin D, I think, is very, very important for everybody, but particularly patients with muscle diseases. And the other thing is always just to kind of keep yourself engaged in all aspects of life, you know, your body, but also your mind. So that's school, that's hobbies, that's friends, that's all those kinds of things. Maybe I'll stop there and pass it on.
So as strength and mobility change over time, families often wonder how much activity is still good for the heart. How do you help patients balance keeping the heart strong without overexertion?
Hi again. Thank you very much for inviting me to come today. That's a tough one as well. I also made some notes. So I follow about 60-something men with Duchenne muscular dystrophy in the cardiology clinic at Toronto General Hospital. We started that clinic maybe 10 years ago to try and keep everybody together in the hopes that for research and for new therapies, we'd at least have a group of people rather than having them spread out in the community. And we've evolved over time to try and make links with different specialties. Exercise, for the patients that I follow, the level of exercise that you would need to do to improve heart function is generally not possible for the patients I follow. So for all of us who are able-bodied and able to do exercise, they recommend about 150 minutes of moderate activity. So that's something where you can't speak and you get breathless when you're doing that level of activity. And of the patients that I follow, the realistic thing is that people can't do that level of activity. That's not to say that I don't think exercise is important for all the reasons you said. I do. What you can do is important, but it's a balance between, I don't want people to feel that they're letting themselves down because they can't do the exercise to keep the heart healthy. That's, I don't think, relevant. I think diet is quite important, not getting hugely overweight, because if you can't do that level of exercise, then it is easy to become overweight. So I think that that's quite important. So you don't put more, so if your heart is struggling, you don't want it to have to supply more body than it needs to. So I think diet's really important. I think exercising where you can. And I think the real benefit of exercise for my patients is really in the social aspect of it. So doing some sort of exercise or some sort of participatory sport, and there are other things you can do without being able to run 150 minutes a week, will really keep your mind active, and keeping those social connections engaged. And mental health is, I think, very, very important. So that's where I think the exercise piece comes in from a cardiac point of view, because to truly do the amount of exercise needed to improve heart muscle, I think is very tricky for somebody with an adult with Duchenne. I don't know in childhood if you were at the point when you can do those kind of activities, if that improves heart outcomes in the long run. And because we know it improves vasculature, if that's good, I don't think there's any data, versus there are some concerns about doing too much exercise for the muscle damage. And that part, I'm afraid, I don't know.
Many people hear palliative care and think it only means end of life. Can you explain what it really means for someone living with DMD day to day?
Thanks, Eloi. Good afternoon, everybody. My name is Adam Rapoport, as you heard, and I'm thrilled to be here. I guess we're going to start right away with the elephant in the room. Yeah, I think it's a great question. Why does everybody associate palliative care with end-of-life care? Can I ask people in the audience, has anybody ever had any experience with palliative care before, with a family member? Anybody heard of it before? And for the people that put their hands up, was it related to end-of-life care? Some are saying no, most are saying yes. And that's where it often comes from, that most people's experience with palliative care is with adults, where it tends to be largely focused on end-of-life care. And I'll explain why in just a second. But the reality is, and your question is, what's the truth about palliative care and how can it help people with DMD and families of children with DMD or young people with DMD? The truth is that palliative care is all about optimizing quality of life. You all probably know that medicine in 2025 is very subspecialized because there's so much knowledge and information out there now. We have neurologists that focus on the nervous system. We have cardiologists that focus on the heart. We've got respirologists that focus on the lungs. We are a team, we're a specialty that steps back and says, wait a minute, there's a whole person here. And not just a whole person, a whole family that's being affected by this, and sometimes even a community. Now, that's not to say that my colleagues here don't think of your kids as a whole person, but they have limited time and a lot to focus on. And so that's why we work together as, different specialties, because that's our main focus, to make sure that every day is as good as possible for children, young people living with a serious illness. That's what palliative care is really all about. And if you don't believe me, you can Google palliative care, look up different definitions, and you will see the same. And so you might be wondering, then why does it always look like end-of-life care? Why is it that the palliative care team tends to be called in when someone is nearing the very end of life? And the main reason for that is because there are a lot of dying adults out there, and they are the individuals that really struggle with quality of life. They're the ones that need help with quality of life, and I'll tell you why in a second. But because there's so many and insufficient resources, what it tends to look like most of the time is end-of-life care. So I'm actually very impressed that some of you said that it wasn't around end of life. That's terrific. Things are certainly shifting. The reason why in pediatrics, we tend to do very little end-of-life care. In fact, when we look at the referrals to my team, less than 10% of all referrals are for end-of-life care. 90% is for what we call supportive care. It's because, thankfully, most kids are healthy. And so we actually have enough resources to achieve the ideals of what palliative care is meant to be, to focus on quality of life. How do we do that for people with DMD? Well, first of all, we get to know them. We know that everybody's different. And what makes life good for you is very unique. It's different for you than it is for somebody else in this audience. And so the first thing we do is we try to get to know every patient individually. And once we do that, then we look at ways to make your life better. And I guess the last thing I'll just say is that if you want to try to improve someone's quality of life when they have a serious illness, it's actually a pretty simple formula. All you have to do is try to make more of the good things in your life. And I got to find out what that is by speaking to you. But once I understand what makes you happy, what brings you joy, I try to make more of that stuff. And then I look at what are the bad things going on in your life, and I try to make less of that stuff. And the bad things are typically physical symptoms that can cause distress and suffering. And even when we're limited in what we can do to cure the underlying condition, there is always more that we can do to improve someone's suffering. That's the first thing. The second thing is helping up here. And that's because that even though I think the parent here, is it Kasha? Kasha had mentioned that most people don't try to think too far ahead and stay in the moment. If you can do that, that's great. But I think it's human nature for all of us to sometimes think about the future and even worry about the future. And if that's true, whether you're a person with DMD or a parent of somebody with DMD or a sibling of somebody with DMD, there's always more that we can do to support you. Talking about difficult things doesn't make them come true. It doesn't make you a bad parent or a bad person, but we can address your fears and worries and support you through those difficult times. Hope I answered your question. Nice guy.
What are the earliest signs of heart problems that families should watch for, and how often should heart monitoring be done?
Okay, that's something people really worry about because obviously the heart's inside, we can't see it. The good news, I guess, is that in all the years I've looked after people with Duchenne muscular dystrophy, I've seen hardly any people develop true symptoms of heart failure in their young adult life. So the symptoms that if I was to get heart failure would be swollen legs, breathlessness, being unable to do things and be able to climb up the stairs and things like that. And largely because of the inability to do those physical things, people with Duchenne's, if they get symptoms, the symptoms are quite late. So I would really be hoping that actually the parents wouldn't really have to worry about what to look after, because you'd be followed by a cardiologist who's looking at your heart regularly and telling you how things are going and reacting to that in individual cases in an appropriate way. So really, I think that's something I try with my patients to tell people not to worry about too much, because I see my patients regularly. And the symptoms are really unlikely to be a problem for most of the time. When people get symptoms, it's usually from their heart. in the course of intercurrent illnesses. So if they have a flu or something, then the underlying heart problem might manifest as heart failure. And so those are the times when I think it is important for parents to be aware of, and for the young men I look after themselves to be aware of things like getting a flu shot every year, really important to avoid those like winter illnesses if possible. And if you do get admitted to hospital with those things, because people's blood pressure is quite low usually as an adult, and some of the medicines we're on lower blood pressure, and normal adult cardiologists and teams know that that lowers blood pressure. And when the patient comes in with low blood pressure and a respiratory infection, they might stop some of those heart failure medications. So for me, one of the things parents and families could be aware of is that if your child gets admitted with a different type of illness, but the medications are reduced, we really need to get back on those when we get discharged, and your cardiologist needs to be involved because we can't suddenly increase the dose. Whereas at SickKids, you might stay in hospital until you're all back on your medicines. In an adult setting, you're going to get discharged as soon as you're well enough to get discharged, because that's just the practice, and you won't be kept there an extra week to get your medications up. So we need to find a strategy for that. So that's the thing from the heart point of view for the parents. But symptoms, I think you can relax. There's very few symptoms that you're going to find before I do if you're under good follow-up with a cardiologist, I think.
When strength or breathing start to change, how do you decide what supports like ventilation or mobility aids will help maintain comfort and independence?
Thanks. So I think the first part here is, again, that conversation with the family and the patient as to what is the actual symptom that's bothering them the most. So understanding what those symptoms actually are, and then working with, as best as we can, a multidisciplinary theme. One of the sort of gaps, I think, that is not hidden at all. I think it's very obvious for anyone who has transitioned to adult care or experienced any sort of healthcare in the adult world, is things tend to be a little bit fragmented and tend to be a little bit siloed. So one specialist is one place, one specialist is somewhere else. You got to get referred over here for one thing and over there for another thing. So I think the first thing is to have that team in place so that we know who is trying to help look after what. As Dr. Rapoport mentioned, when we're subspecialized, we can't always manage all the different aspects that are relevant. So we have to rely on our colleagues in cardiology and respirology, and also physiatry, which is like rehabilitation medicine. So I often will refer there as well for help with wheelchairs and mobility aids, things of that nature. Because again, I don't have specific training in those specific areas. So we have to really end up relying on a lot of our colleagues. And that's where the fragmentation makes it a little bit difficult, because each of those ends up being a different visit, and each of those ends up being potentially in a different location. So it's quite a burden for everybody involved, unfortunately, but it is something that I think is still important at the end of the day. And so we look to you to tell us, what the main issues are, and then we guide what we do from there, trying to leverage the help we get from our subspecialty colleagues.
When big medical decisions come up, such as starting breathing or feeding support, how can palliative care help families talk through these choices in a way that feels supportive and not overwhelming?
So another great question. So what we do that's a little bit different from other medical teams is, well, let's start with how other medical teams often approach decision-making. I'm sure everybody here has had some interactions with the medical community, either because of your children or yourselves. Most of the time, when medical people try to help you make decisions, we look at the various options in front of you, and we try to weigh out the risks and the benefits of those options. And I would say, 99% of the time that works. That's something that we can all listen to and be able to make good medical decisions. But there are some very difficult decisions, like the ones that you mentioned, Eloi, that are a little bit more complicated. It's more than just the risks and benefits of a G-tube or starting something like BiPAP, because those things are not just about the device themselves. They're about the impact on the rest of the family. They're about the impact on you psychologically and socially. They're about the impact on your quality of life. They're much bigger, and it's really difficult to sort of just bring it down to risks and benefits. Again, I will say, though, that many people just hearing the risks and benefits alone, that's good enough. But if you're challenged, if you're having a hard time making these sort of complex medical decisions that a lot of people I find do struggle with, a lot of families struggle with what's the right thing to do. Do I use feeding tubes? Do I use technology for breathing? What's the right choice for us? The palliative care teams take a slightly different approach. What we do is we help you and your family identify goals of care. And we do that by sort of looking at what matters most to you in life, what's most important to you as your body starts to deteriorate and as you get sicker. What kind of things worry you? What might you be scared about? What's keeping you up at night? These are hard things to talk about, but they're often in there. They're things that you're already thinking about. And once we hear those things, we can help operationalize them into goals of care, bigger picture things that we are trying to achieve. And so rather than focusing on the decision in front of us, G-tube, BiPAP, trach and vent, we use goals of care as our North Star. It's something that we're trying to aim towards. And once we have our North Star, once we know what we want to do and what matters most to us, then we look at the individual decisions, and it's a bit of a different way of looking at it. Instead of the pros and cons and the risks and benefits, we say, is this technology, is this apparatus, is this decision going to bring us closer to what matters most to us or further away? So that's the main way that palliative care teams can help patients with DMD and families of patients with DMD think about these things. The other thing that I think I often find myself doing is, sometimes to the chagrin of my other colleagues, but I do think there's value in this, I try to lessen the stakes of the decision. Now, the truth is we don't want to surgically place a tube in somebody that really doesn't want to have it, and it's not going to be helpful. And we don't want to start BiPAP in someone that really never wanted BiPAP. So we like to try to get it right the first time. But I know from working with so many families and patients that are faced with these decisions that it feels like such a big decision. This is it. I got to decide, and the rest of my life is going to depend on it. Either I go this way or I go that way. And this is the moment that I have to make such a big decision. But the reality is that it's okay if you get it wrong. We put G-tubes in, and sometimes they don't achieve those goals that we're trying to achieve, and we can take them out. We start BiPAP and other medications and other technology, and sometimes they achieve the goals that we're after, and they lead to all the good outcomes that we were hoping, and sometimes they don't. And if they don't, there's no reason why we can't stop them.
What helps teenagers and young adults with DMD feel more confident and involved in their own care as they move into adulthood?
This is a tough one. I got to think back to when I was a teenager, which is a very long time ago, or feels like a very long time ago anyway. But I think being a teenager is not an easy thing at the best of times, right? So for me, I think it's, and honestly, I think the pediatricians in the room probably can speak to this better, but I think there is a transition that occurs where it goes from being very parent-driven interactions to giving some more independence to the actual patient themselves to drive the interaction. And I think that's a big part of it, that you're listening to the actual patient that's there, the teenager who's coming and getting transitioned into the adult world for what their problems are, and letting them answer their own questions and guide some of what the discussions are, rather than being kind of top down from maybe what the parents are interested in. We do see that divisions start to occur a little bit often in a lot of the transitions that I see. And I think that helps build trust in the healthcare system. If they trust the physician that they're talking to, I think they're more likely to open up and, give us the issues that are happening earlier so that we can try to address them and get things treated in an earlier way, instead of like what I was saying before. If you wait too long, sometimes it makes it a lot harder to come to a proper solution at the end of the day. The other thing is that, I like to direct people to the supports that exist out there, including the Muscular Dystrophy Canada, which many of you are familiar with. And a lot of my patients do find that those kinds of supports online and whatnot can be very, very helpful. And so we do approach many of those things in the visits that we have. But yeah, I think that's mostly what it is, giving them a sense of independence and that they're now taking more charge of their own care and having more responsibility for their care. So if we give them that exercise prescription, the next time I see them, well, did you try those exercises and how did it go? That kind of thing. And so a little more onus is on the patient themselves to sort of drive a lot of what we do.
Families often struggle to discuss hopes, fears, or long-term planning. What's a healthy way to start these conversations, and when is the right time?
So it's a great question. It's true. I think a lot of us have difficulty talking about these things because sometimes it can open up a lot of hard subjects. My sense is that everybody here, just judging by the name of this conference, everybody here knows somebody affected by a serious illness. And, again, maybe I might just ask by a show of hands, for the people in your lives with DMD, how many of you want to protect them from difficult things? Exactly. So all of us want to protect our children from hard things. But the reality is there are some things we can't protect our kids from. What we can do, the biggest gift, is we can prepare them. The other thing is that just because we're not speaking about things doesn't mean that people aren't worried about them. And when we tell our kids, you don't have to worry about that, or it's going to be fine. I know whenever my parents told me, don't worry about that, what it meant is I got to worry more. And it also meant that I can't talk about this with the people that love me and that I want to discuss it with. And so I think the answer to your question, Eloi, is that as much as it's possible to really try to open up those conversations and to give the person in your life with DMD, or if it's yourself, to really think about how much I want to talk about. I often describe these sort of emotional conversations as peeling back the layers of an onion. There's no need to go right to the center. You go step by step and you talk about things as they come up. And when you say, I've had enough and I don't want to speak about that, then we stop. There's no need. The goal of these conversations about hopes and wishes and worries and fears is not to make people talk about things that they don't want to talk about. It's to open up a conversation about things that we do want to talk about. And so that's really the main goal here, to explore and create an opening. The other thing to remember is, just like all of you want to protect your children from difficult things, your children want to protect you from difficult things. They can see you getting upset about some things. They know that these things are hard for you to speak about as well. And that's, again, where the role of your physicians that look after you regularly, like your cardiologist and your neurologist, your family physician, or potentially a palliative care specialist, can sort of help. Because we can speak with you on your own if it's difficult to talk about some of these hard things with your parents. But the more we talk about it, the more we can understand what matters most to you as things change. And for the people out there that are trying to help you make decisions, actually, there can be nothing more beneficial than knowing what you want for your body, because it's so hard to make these tough decisions for the people we love. All of us in this room probably know what we would want if it was ourselves, but making these tough decisions for your child, it's a whole other ball game, pun intended with the J's. So if you can weigh in and share with your family what matters most to you, what you're hoping for as things change, what you're worried about, then that can guide everybody about what's the best way to care for you. So again, I think speaking to your health, first of all, speaking as families, opening it up. It sounds like a terrifying thing to do. It'll be awkward at first, but actually once you start talking, it feels like there's a weight lifted off your shoulders. There's no more secrets and we can talk about anything. To speak to the healthcare providers who are looking after you and making sure that if it's not the kind of thing you want to talk about in front of mom and dad because you don't want to upset them, making sure that your healthcare providers give you some time to speak alone. The last thing is there are actually, workbooks and stuff like that where people can do these things on their own, start to think about the questions about what I want as I get older, how I want to be treated, what matters most to me, things that I don't want. And those things can be filled out. I often recommend to do it with a healthcare provider. They're not really sort of the kind of thing that you just want to do on your own, because I think there's often a lot of medical questions, but they can really be helpful as well. One last thing I'll say about it, you can always change your mind. Things that you say that matter most to you now might change down the road, and that's okay. You might say, I don't want breathing machines. That's not something I want. But maybe when you start getting into trouble with breathing, you might actually really want it, and it might help you live a longer and better life. The opposite can be true too. So things are always changing as we grow, as we get older, and so we need to have these conversations regularly. Maybe I'll say one last thing. It's sort of like exercising. The more you exercise your muscles, the stronger they come. The more you normalize these discussions and talk about these things together with someone you trust, your family members, the easier they actually become.
We've heard so much about new therapies for DMD. From your perspective, how are these advances changing what families can expect for heart health in the future?
So there's lots of heart failure medications that we use that are shown to be very beneficial in the general population. Really, there's 4 medications that everybody in the general population who had heart failure would be on, and they are shown to improve survival, reduce hospital admissions. The data in people with Duchenne's is quite different. Well, there's much less of it. There's been far fewer trials. It's much less robust. And the recommendations and guidelines are kind of varied about it. So we do different things. And I really think, back to what everybody has said, it's a very individual decision about what kind of medications people want to be on, and what's right for one person might not be right for the next person that I see. And in my clinic, sometimes I'll have brothers from different families. I try to really treat people as an individual. I don't see 2 brothers together. I see them maybe on the same day for making the ease of transport, but I will see them in different rooms to have a conversation with that individual patient on their own about what they want to do. There are some medicines that we use. Most people come from SickKids. I've actually done a study looking at all the medicines that people are on. About 75% of people are on something called either an ACE inhibitor or an ARB when they come from SickKids to my clinic. That's a good medicine for heart failure. And that's the one with the most data in Duchenne. The rest of them are much less clear-cut whether or not people can benefit from them, and we make decisions about that usually as people's heart function declines, trying to bear in mind that actually medications cost money, and they make people feel different. If you have to take medicines every day, you feel much more like a patient. So if it's not of clear benefit, some people don't want to take them for that reason, and some of the side effects make the blood pressure lower. And I have had patients who want to be on medications or who are on them, whose blood pressure is very low, who then fall because they're still able to transfer, but fall and break a leg. I've had more than one person do that with the low blood pressure. And therefore, you have to balance in, is it really worth it to take a medication that we don't have a benefit for sure, that then clearly can have an adverse effect? So we really try and balance those things. But back to these conversations, which are difficult to have because you have to talk about the long-term outcomes and potential bad outcomes. I do feel like talking to the individual patient with Duchenne allows them to have some control over the choices that are made. And I hope that that makes people feel, just giving people that sense of control, I think really helps people's mental health and help them feel that they're deciding things about the way they want to live and how they want to manage their heart. So that's the kind of thing we have conversations over a period of time about. And I have it differently with different people, because clearly in different families, the amount of this conversation that's gone on beforehand and the amount that the patient has been allowed to make decisions or sheltered from decisions is very variable. So we kind of gradually find our way into that over time. But as yet, unfortunately, there is no miraculous drug that's going to fix the heart of somebody with Duchenne that I know about. And maybe some of the gene therapies in the long run will be more helpful. I suspect that will be where the heart improvement comes from. But still, even now with the steroids that people take, there's not really good data on that, but we're trying to look at that. I do see better heart, just as anecdotal from my experience of maybe 20-something years looking after patients. I do see people's heart seems to be a bit better than it was when I was training and actually doing pediatrics, when I saw a lot of patients with pediatric heart failure. That's why I kind of continue to follow the patients as adults. I see that less. And still in my practice, and if I look at the outcomes, the respiratory outcomes are more important than the cardiac outcomes at the moment in terms of heart failure still.
So the next couple of questions are for everybody who always, and then we'll open up. If you have questions before that, please just raise your hand, okay? But now whoever wants to take the question, just go for it.
Looking back on the patients and families you've followed over the years, what have you learned from them that changed how you practice today?
Maybe I'll just start because a lot of what you heard already from Dr. Roche and Dr. Rapoport resonates very much with me as well, and I think feeds into this question a little bit. I think my answer would be sometimes less is more, and that we, sometimes in medicine we have a bit of a top-down approach, and so every patient is different. Some patients don't want to feel like they have a disease, right? They don't want to talk about it. That's not what they're interested in. Everybody approaches their disease in a different way, and I think it's important to respect how that, how they want to be managed, how they want to have the discussion. So for me, it's listening and then managing things in that way, not pushing a medication, for example, that may be of marginal benefit but have its own set of side effects, or pushing something on. Like for example, the exercise, right? That's a guideline, that's a recommendation, but I'm not going to, I don't want it to be a top-down issue. It has to be a decision among everybody. And then the second thing I'll point out is the frustrations that I've heard about from families about sort of the fragmentation of the care that they start to experience, as soon as the transition occurs, because the adult world does have that fragmentation, which, I'm hoping that at some point we can make some changes to improve that and to reduce some of that. But I think that the frustration there definitely exists. It's definitely a different world when you transition. Because we don't have those same resources all in one spot for everybody. And we're sort of grasping and we're trying to use all the same resources that, just like palliative care is very different from adults, for adults maybe than it is for children. When you transfer and you transition, you're now part of that giant group of adults who are in the healthcare system and trying to share the resources among them, which becomes very, very challenging.
I would say the same thing. My other hat is I'm a pediatric cardiologist and an adult congenital heart disease specialist. So I look after unique groups of patients, and I trained as a pediatric cardiologist. And what I saw in pediatric life is that people with pediatric cardiology needs are a big part of a pediatric hospital. They're the largest group of patients generally in a pediatric hospital, and they get a lot of resources. When they transition to adult care, they're the smallest part of a cardiology group, let alone the whole hospital. And it's very hard there's no resources. And the thing I have learned the most is it's very frustrating for parents and patients that problem. And I really think there needs to be a more political solution to the whole thing. That's what I have really come to think. I don't know how to do it. So I feel frustrated by not being able to advocate more for people, but I really think that you guys are a powerful group, even down to that, this cost of this. I don't know if you've talked about this cost of the steroids thing, that my patients can't afford it. That's a huge problem and shouldn't be allowed, in my opinion. I think you guys are really powerful and you've got a powerful case, but I don't know how we advocate more. That's the thing I've learned, but I haven't found the answer to it.
I guess I would just reinforce what Charles said, that from my perspective, the thing that stuck with me most over my career, from all the patients I've cared for, is how everybody is an individual. When we trained, we learned about groups of patients. So we have guidelines that say if the heart function is at this level, you do this. If it's at this level, you do that. If if your FEV1, your breathing is at this level, you take this course, and if it's less, you do that. And I think that's a great place to start. We generate data from research, which is looking at collective groups, and so we make recommendations. But when it comes down to it, every patient, every person is unique. And although the data is supposed to lead us in the right direction, it doesn't always. I'm really pleased to see SickKids' current motto is all about precision child health. This new idea is making sure that the medicine and the healthcare that we offer to children is really meant for them, that every child is going to get unique care. And that's what we've been, I know we're all trying to do it, but it's something that I really value. It's one of the reasons I went into palliative care, because we really focus on making sure that we're treating individual patients and individual families. Everybody is unique. There is not a one-size-fits-all. And as I mentioned in my last response, it's changing all the time. That's what human beings do, right? We're changing all the time. We're growing. We're thinking about things differently. And so the way we approach our healthcare has to change with it. And so that's something that I think all the patients over the years have shown me, Eloi.
DMD care involves many specialists and transitions. What do you think still needs to change in the healthcare system to make life smoother for families?
Maybe since I'm holding the mic, I can start. I should say that the truth is I don't have a lot of direct involvement with young people transitioning with DMD to adulthood. I think part of that has to do with how well the healthcare system has done improving life and health for young people with DMD. But I will say that I work with a lot of young people with chronic complex medical conditions like DMD and their families. And I'm hearing one thing over and over, that the transition from the pediatric side to the adult side is a very, very difficult transition to make. And I think that we as a healthcare system, we as pediatricians and our adult colleagues, we have to start working together with families and with patients to understand where are the obstacles, where are the bumps, and to try to make things better. I think that that's the biggest challenge for us right now. How do you smooth that transition from pediatric to adult? It's unintentionally been sort of a theme, I think, of all these questions about how different it is on one side, and I hear it from parents all the time. And I think that there's a lot of work to be done there. And I do think that at the heart of it, this is sort of the flavor of the month, if you will. I think the healthcare system says this a lot, but for good reason, because it's true. It can't be just the medical people that are putting forward the answers. I actually think that the best people to tell us what needs to improve are the patients and the families. Ultimately, the healthcare system is here for you to make life better for you, and you're in the best position to tell us what's not working and what needs to improve. I think you're saying it loud and clear, to be honest with you. I think that we're just sort of slow to listen. And I also think that we have our own ideas about how this system has to occur between pediatrics and adults. But keep speaking up, keep being loud, keep advocating. Your voices are being heard, and I think things are going to start to change.
Yeah, there's maybe a lot more history of transition in my other thing, congenital heart disease or diabetes care. And so some of those models will be useful, I think, that we could use. But I really think, is there a transition program for Duchenne? I don't think there is. Is there like...
I know they're working on it in Ottawa. It's still new because boys are finally living longer, which is great.
Yeah.
But I think that's the path they're on. So soon, as more boys transition, the program itself is going to grow and get better because you're going to have more babies.
Yeah. At the moment in SickKids, the cardiology part really works because when I was a trainee, I trained in the heart function clinic at SickKids, and then I set up the ACHD heart function clinic. So I knew those people, and so they transfer them to me, but that's not really transition. So there's a different thing that needs to happen, which is usually like some shared care, some visits where the person goes over there, and then a much more linked up group of doctors and nurses and the ancillary people, not just the doctors, palliative care. We've kind of built a little community of people to refer people to. I do refer them to our ACHD supportive care clinic, but it definitely needs to be improved, I think.
Yeah, I agree. I think a lot of it has been said already, so I won't necessarily repeat it. But Hernan has done a fantastic job. I know this is something that he's very passionate about. So we've been trying to work on at least smoothing I agree with what you said too, the transfer process. I don't think we quite have a full-fledged transition process where everything in one spot is seamlessly integrated in another spot. I think that's the future case scenario that we're not quite there yet, but the transfer process has improved dramatically. There's, a lot of the patients from SickKids, for example, I've been seeing them in that transition period. But I think that part of the problem is the fragmentation and the fact that exactly as you said, you've gone from being, one patient out of a relatively small group to now being a patient in a much larger pool where the resources are spread much more thin and the priority is not there for this specific disease. So that's why we need to, I think there are specific resources that I think would be very, very helpful. A clinic with specific resources, physiotherapy, respiratory therapy, et cetera, kind of like a one-spot shop sort of thing. So we want to open it up. Is that what you're saying? Yeah.
So
Maybe
last 10 minutes. So I would like to have questions we have 2 more questions here. If there's no questions, but I'm pretty sure you guys want to have some thoughts and opinions and open it up. I'm not sure if you guys have any questions.
I think I saw a hand actually. Yeah.
If and when you allow me, just wanted to reiterate that in Quebec City, because where we are in the transition adulthood, and it's much less as a black hole as we thought it would be. Because at the neuromuscular clinic, there's been a real transfer. And fortunately, physiatrist is taking over most, but he already doing well because we're doing pediatric in adulthood. And same cardiologist and all the recommendations, endocrinology and pneumology will also transfer. And we have a hospital that is specialized in neuromuscular. So that's, or neurology, that's the whole, so. Yeah, no, unless I'm mistaken, it will be the transition. The process has been, much facilitated.
That's good to hear.
Any other questions, comments?
Europe. What's the gold standard to look at? Talking about things that happen. Is there a model out there that we should look at that's been done on
But I can different than Dr. Roche that I am actually an adult and came to pediatrics.
Oh, the other
Funny
way
that
around.
you went, yes, I went the other way. I mean, I come from Argentina, extremely low resources. And over there, we have a multi-D for pediatrics and a multi-D for adults. And I was so shocked when I came to Toronto, and I remember having a dinner with all the adult neuromuscular specialists, like, why so fragmented? Maybe it's Quebec's particular. Oh, and I know in Chile, I mean, there's a huge multidisciplinary group of neuromuscular dedicated in Ottawa, but it's not the case in Toronto. And I know BC is like also trying to work around it. And it's not. I don't think it's homogeneous everywhere, but the ideal will be that we have actually a multi-D that we actually can transition. And we actually were able to work with motor neuron disorders for the SMA population. We were able to do that here in Toronto. But for myopathies, for muscle disorders, and that's why I want to really support Charles to actually get more support, because basically like he doesn't have it. And then we need to send the patients, you guys, you families, to like so many different places, because basically there's no centralized place that can support it. And I think that's what I think you guys need to advocate for. I don't know if you guys have any thoughts.
Should be one place, ideally. People should go to one place. It's very difficult to go to 5 or 6 different places, and people have to take a day off work to come. Like, these patients are unable generally to come on their own. So it's 2 people have to be off of whatever they're doing to get to all the places. We have a clinic for 22q11 deletion syndrome in Toronto, which is also a multidisciplinary thing, a small group of patients, but it was funded, the whole thing, by a very wealthy parent of a patient. So they set up the whole clinic, and that's the problem is money. That's why it needs a political solution. This would be sorted easy. I mean, it's very easy to sort out if there were money, I think. Like, do you
because I've done some work with CORD, the Canadian Organization of Rare Disease, and this has come up on the table, and I'm all about advocacy, but I'm wondering, do you envision or do you see possibility in a center of excellence for rare disease? Because like when I start connecting with other rare communities, there's a lot of overlapping things happening, but not the right person for the right care at the right time. And so it's like, part of me is like, could we advocate for this? I'm just speaking out like outwardly right now, but like what would need to happen for that to come to fruition, I guess? And what would that look like? Or at minimum, do we see a model of care where we use telehealth for support and more coordinated, seamless care transitions where they can pair up with their existing provider? But then I think, what is the capacity? Like, this is where my head goes from a systems perspective. I don't even know how much overlap happens now between specialists from pediatric to adulthood. Is there some mentorship and overlap that happened there? I'm anticipating my son is in his teen years, but I'm thinking already ahead, like what could we do to strengthen this?
Yeah, I don't know the answer to all those. Those are really good questions that I don't have a clear answer for. I think a lot of those are the main issues that exist, which is that unfortunately, the fragmentation isn't just the fragmentation of the specialists and where they're located. I think it's the fragmentation of how everything is funded by disease, right? So, for example, if you get a wealthy donor that's interested in, Duchenne or cystic fibrosis, or whatever, you suddenly get a cystic fibrosis clinic, even though, that 90% of what they do there could actually benefit a whole bunch of other diseases, but everything is kind of very siloed in those specific things. And even the sites you donate to SickKids, money is not going to help a adult hospital. Like those things do not connect with each other in a way that's actually helpful because the patient is not what's at the center of that. It's the disease may be in the center of that, or a specific site is at the center of that, rather than thinking of the patient holistically or a bunch of patients. I think that's a major problem. And the fact that, for example, it's great that CHIO is doing that, but I actually think that that's indicative of the problem, because it's a lack of national at the end of the day, healthcare is provincial. So I would say it's lack of a provincial impetus to say we're going to fund, all the big centers are going to have a complex disease center, or let's even make it simpler, a muscular dystrophy or a neuromuscular disease center for transition. So that means that CHIO doesn't have to create their own thing because they happen to have gotten a donation. Meanwhile, we don't have a donation, so we're kind of stuck in Toronto, right? Everyone's kind of just almost left to figure it out on their own. That's, I think, one of the problems. We're all just kind of left there and be like, good luck. Okay, maybe you find a donor here. Maybe someone's interested over there. I think that's the problem that we're in now. Everyone's just sorting it out on their own instead of having a central place that says, okay, in the province, we have X number of millions of people. For each population of X size, we need one neuromuscular center of excellence. So we're going to put one here, put one here, put one here, and then fund those so that they're multidisciplinary clinics. I think that's ultimately kind of where we need to be. But it's going to take a while to get there.
Another thing that I don't know if you know, but like another funding thing, there's a fundamental problem with the funding thing. So at SickKids, in the adult world, it's a fee-for-service model. So you get paid for what you do. So for instance, for virtual care, you don't get paid to see somebody as a follow-up unless you, like as a new patient on virtual care, the same money in Ontario as if you're seeing them in person. And the service is funded as a fee-for-service thing. So there's no extra, like SickKids is not funded like that. The doctors are not paid as a fee-for-service, most of them. And so there is extra money in the system to fund nurses and nurse practitioners, which there are not in the adult practice. So in some way, these rare diseases need to be funded totally differently. I think that's why I said at the beginning, what I've learned is a big political problem. And also coming from, you can hear I'm British, coming from the NHS, I was staggered by all of this when I got here, and I've only learned about it, but I don't know the answer.
Hi, sorry, I'm kind of walking into the conversation at the end, but this is really interesting. My question for the panel is, as a patient organization, should we be increasing our advocacy efforts to provincial healthcare systems to advocate for these types of, funding, first of all, but then, there's the funding piece, but then there's also who coordinates that, who makes the decision on what that looks like. So how would a patient organization approach that?
Well, I can tell you, sorry, I'm like jumping. So I think you need to grab all the physicians, first of all, and say, hey, like put in the same room, who's going to take over that, and then get your like support, because you guys are going to like, we have been complaining to the, like at the hospital, although SickKids, like, oh, SickKids, we love SickKids. Like the truth is there's also political level at SickKids in the hospital. Like the family association has more push to actually say, we need these resources, then they will get it. Like on our side, SickKids didn't have a physiotherapist until recently. Like, and we didn't get it. Like we just didn't have it. OT, we don't have it. Dietitian, we don't have it. So, and I'm been for the last 5 years, like basically I've been pushing to get resources, and now we have a nurse educator. Like we have been growing, but the truth is like we don't have it. And I understand that like in terms when we think about donations and funding, and we want to have the best medication, gene therapy, you need to also think about the hospitals and actually have the eventually physicians. For example, at SickKids, when I arrived, there was no clinical trials. Now we actually run into clinical trials. And why that's important? Because you don't need to go to a city in US to actually get these trials. So it's important that, yes, we support the research, but also support how we actually advocate for the actual day-to-day care. Sorry, I need to say something. I know I'm the moderator, but I'm like really passionate about this part. Someone else.
No, I think you hit the nail on the head on that.
Then are you saying we're lobbying the Minister of Health in Ontario? Is that who we need to go to and say,
Yeah.
right?
What's actually missing in my daily care that is actually having, like, it's a problem for me. I can't be traveling to 5 different institutions that are like 20, 15 or 5 kilometers away from my house. Let's just try to organize something that it makes sense for eventually the community. And you should guys decide, okay, what's the best eventually in the 5, 6 big centers across Canada, how we actually do it. Because we have ideas, but the truth is that you guys need to do it.
And to answer the question that you asked how other places do it, I think part of the problem is that our geography is wonderful in Canada, but it's also probably the biggest barrier to actually getting these things done. I think about like a place like the Netherlands that has a very sort of organized healthcare system, but the area of their whole country is like, barely just the southwestern Ontario, right? Right. So for example, they have a very integrated healthcare system. They have great healthcare records that span throughout that healthcare system. People can easily travel, and there's a lot of regulation about that. Here, every hospital is its own entity.
That's another
right. So we're very geographically broad. It's very hard.
In the congenital heart disease thing is the same thing. I can't really compare what happens in the UK because there's so many more people and it's all so much closer together and there's so much more money. But something like Australia strikes me as a fairly similar setup, right?
There are 2 tiers just
around the edge. Well, yeah, but they have a public healthcare for sure. They also have a native Australian population. They're very similar in some ways to Canada. So how do they provide care? Maybe they have an idea. I don't know. These are things like over the years I've been thinking what is similar that you could borrow ideas from. But I do think we will all do whatever you think is best. But I do think we cannot persuade people to raise the money, and you guys probably can. And you have a disease that has a very visual aspect to it. People can see your children and see what the problems you might have are. And so I would hope that you would be able to get politicians interested.
Another big change usually happens, like I saw it with the SMA population, is like once you have a drug and you have industry, that I need to be honest with you guys, like that's when you eventually money starts flowing. So I don't know, maybe with Vamorolone approval, like now you guys can think about it, how to do it. I mean, we have done it with Sunnybrook with the SMA. They actually put a nice multidisciplinary care there for motor neuron conditions to actually follow the patients over there, and they're actually running. We did it in the last 5 years. It's actually running really well. It's going to be sustainable. We're hopeful. I mean, we did it through research, so we actually can show to the ministry this is actually impactful, that we're actually changing the quality of life of the families, and maybe that's the way for you guys to go.